Good morning. My name is Shirley Franklin, and I have the pleasure of introducing our keynote speaker, Dr. Brian Rivers. Dr. Rivers is professor and director of Cancer Health Equity Institute at Morehouse School of Medicine. His full biography is available on the Summit website, but let me share a little bit about his background. He's nationally and internationally recognized as a leader in health disparities research, and he is a retired member of the NIH National Advisory Council on Minority Health and Health Disparities. A behavioral scientist with a broad background in dissemination and implementation science and public health, Dr. Rivers' specific training and expertise is in the methodologies commonly used to address health disparities. His research portfolio focuses on the application of population-based intervention science to understand how to address cancer health disparities in clinical and community-based settings, utilizing multi-level approaches. He holds a Bachelor of Science degree in biology from Vanderbilt University, a Master of Science in Public Health from Morehouse School of Medicine, and a Doctor of Philosophy in Health Behavior from the University of Alabama. Please join me in welcoming Dr. Brian Rivers.
Good day. I'd like to thank the organizers for the invitation to serve as a keynote speaker for this, what has been already a great event. And definitely looking forward to the breakout sessions later on this afternoon. Well, good day. My name is Brian Rivers. I serve as professor and director of the Cancer Health Equity Institute at Morehouse School of Medicine. Also, I serve as co-chair of the Georgia Cancer Control Consortium, or GC3. And today I'd like to speak with you for about the next 15-20 minutes from the topic of advancing cancer health equity in Georgia through cancer prevention and control, a statewide approach. So 2021 is a historical year, I guess, in the cancer world, in that it marks the 50th anniversary of the National Cancer Act of 1971. This key legislation was signed by then President Nixon, which really, broadened the authority and power of the National Cancer Institute at the National Institutes of Health, and established some of the key programs that were many think has served as the backbone then as well as now of today's cancer research enterprise. This single piece of legislation called for the establishment of cancer centers, or NCI designated cancer centers, as we now refer to many of them, networks of clinical trials to increase representation of individuals in clinical trials, especially those from diverse backgrounds. This legislation also called for the establishment of new ways in which we collect data, especially at the patient level, that really help inform different models of care as well as models of prevention. And then lastly, this legislation helped with the advancement of cancer research. And some of the key factors that have been attenuated in terms of why this legislation was even made possible. And I took this quote here from the National Cancer Institute's website, and I like it in that it really shows forth the involvement of all individuals in this war on cancer, as what some have deemed the signing of this key legislation by President Nixon as signaling. As you can see from this quote, there's an acknowledgement of the role of advocates, the role of advocacy toward really advancing key strategies toward cancer prevention and control, the role of researchers as well as scientists who are making seminal discoveries and translating those discoveries to clinical practice, but then also taking those similar discoveries to the curbside or to various communities. And then also now, as we've seen most recently, to help inform policy. Then also, of course, the role of doctors and other physicians, scientists, who are really delivering novel, innovative models of care And then also the role of social workers, patient educators, administrators, technicians, and then most importantly, those patients, those friends, those family members, those community members that we see day in and day out, realizing that, it takes everyone. It's not just a singular approach that's needed when it comes to addressing issues related to cancer care, as well as prevention. And so, with that as a backdrop, one thing is for sure is that we still have work to do. I think we've made tremendous progress over the last 50 years as it relates to better understanding cancer, better ways of diagnosing it and treating cancer, then also preventing cancer as well, and then understanding cancer in the context of those individuals who are actually surviving cancer and some of the sequence of events that happen post-treatment, what some may deem as the late and long-term effects of cancer. We've made tremendous progress in our understanding of cancer and also developing certain interventions around addressing cancer. But here in the state of Georgia, cancer remains the second leading cause of death in the state, realizing that there are 4 types of cancer that account for more than half of all cancer deaths. These include lung, colorectal, breast, as well as prostate. And lung and colon, must be acknowledged, continue to be the 2 leading causes of cancer-related deaths. But then we also see, as we see nationally, we see in the state of Georgia, the disproportionate impact of cancer on some populations in comparison to others. For example, Black males are 19% more likely than white males to die from cancer, while Black females are 9% more likely to die of cancer than white females. And again, there's been a lot of research funded over the past couple of decades, really trying to better understand why do we see this disproportionate impact among certain groups or populations here in this country, especially here in the state of Georgia. And then we also know, if we look at data at the county level, that those counties such as Cobb and Douglas and Fulton and DeKalb have a much higher incidence of certain cancers, and in this case, breast cancer, compared to other areas around the state of Georgia. And so, the question again begs itself, why do we see this disproportionate impact? And considering, the why, I think going forward to help us better understand the context or the place in which, cancer manifests itself, we have to understand, key constructs, if you will, or the upstream factors that may contribute to downstream outcomes. So here's some data from the Economic Research Service that really talks about the distribution of poverty and different poverty rates in this country. And in this slide, there's a depiction of looking at the United States in 4 different areas: Northeast, Midwest, West, and South, and then comparing these different regions based on the rate of poverty in non-metro areas versus metro areas. And some of the conclusions that can be drawn, from this depiction or this display of data is that people living in poverty tend to be clustered in certain regions or counties or neighborhoods, rather than seeing this even distribution of poverty across the nation. There's been various research studies that have shown that those who are actually living in areas of poverty, face impediments beyond their own individual control. And some of these issues manifest themselves in terms of poor housing and health conditions, living in areas that have higher crime rates, also areas where school dropout rates are extremely high, as well as employment dislocations. And so, as a result, economic conditions in various areas create these limited opportunities for poor residents that become, self-perpetuating. And then also, even more so, we, as we look at this distribution of poverty rates here in the United States, we see, in non-metro areas in the South in particular, they have some of the most highest poverty rates in the country, followed by, if you did a comparison of the metro poverty rates, and still highest in the South. And so there's a unique story going on in the South in our non-metro areas as well as within our metro areas that we must attend to as we begin to really advance cancer prevention and control here in the state of Georgia. And then realizing again that we have this disproportionate impact of cancer. We also see this disproportionate impact of poverty among different racial and ethnic groups. Again, looking at data from the Economic Research Service, we see that African Americans or Blacks who reside in non-metro areas have some of the highest poverty rates in comparison to individuals who reside in other non-metro areas. And then in terms of those who reside in metro areas, again, we see Blacks or African Americans having the highest rates of poverty in comparison to other racial and ethnic groups. And interesting enough, American Indian and Alaska Native are right behind Blacks or African Americans in terms of experiencing poverty. And so why is this important? Because we know that the context or the place in which one resides is extremely important to health and wellness. And we know some of the barriers related to poverty include having a lack of a primary care physician or being able to access care efficiently, whether one resides in non-metro or metro areas, competing survival priorities on the side of the individual. Those individuals more likely to have comorbidities that they have to, manage effectively. Health insurance or having enough health insurance to properly access care and to receive, quality care, is a key factor or a key barrier created through poverty. And then we know that lack of information and knowledge, being able to engage in risk promoting lifestyles, and then being able to navigate health systems at the provider and system level, all barriers that have been shown to be related to poverty. So very, fragmented, non-coordinated system that we find individuals who reside in poverty in facing. And I think we really saw this manifest itself during the coronavirus pandemic. And we saw numerous stories, print, on video, really detailing the impact of COVID-19 on various social determinants, as we call them. And then we see, in most cases, minorities or racial and ethnic groups, various racial and ethnic groups were disproportionately impacted in comparison to other populations. And so in this slide, we see that Black and Hispanic children are impacted more severely by the coronavirus. According to research data, and this was published on CNN Health, there was an increase in higher case rates, hospitalizations, and virus-related complications seen among Black and Hispanic children. In terms of healthcare access and utilization, we really saw a clear picture of some of the technological gaps, again, in metro and non-metro areas, who had access to really participate in telemedicine and who encounter numerous constraints to trying to, in their attempt to participate in telemedicine, realizing that there was disproportionality in terms of who could access technology efficiently and effectively, and then again, those who couldn't. And then where one works, we saw that, realizing that minority populations are more likely to be represented in the jobs that are considered essential jobs. And so, we saw a higher rate of acquisition of COVID-19 among these individuals that worked in various sectors, such as the nursing care facilities, that is comprised of 45% of people of color, or building cleaning services, where that's comprised of 57% people of color, and then those who operate in the bus services and urban transit field. Again, we see a high proportion of people of color operating in these different areas, and these jobs place them at an increased risk for the acquisition of COVID-19. So, where one works was then became a risk factor for COVID-19. And then just in terms of what COVID did to our school systems, our education, wealth, and income gaps, just be more amplified, and seeing that, a lot of the schools that prior to the pandemic were encountering racial and economic inequalities. Those inequalities were, amplified, if you will, and really attenuated to some adverse outcomes, as well as projections for the next 5 to 10 years in terms of the gap in just becoming wider, much wider or divided in terms of education, wealth, as well as income. And then the eviction crisis, really had a disproportionate impact on Black and Latinx renters, as well as renters with children, where this article, it was estimated 30 to 40 million people in America were at risk for an eviction as a result of COVID-19. And again, people of color being twice as likely to be impacted in comparison to other racial and ethnic groups. And then lastly, just what COVID-19 meant to our healthcare system and how our health systems were just overpopulated with cases, space constraints, among other factors really became an issue, and it prevented individuals who were managing chronic conditions or individuals who may have been on active treatment for cancer or other chronic conditions. It truncated to some degree their ability to effectively interface with the healthcare system. And so we really saw COVID and the role of social determinants really speak loud to us all. Right? We knew place mattered. We knew the environment mattered. The physical environment was a factor in terms of health outcomes, but I think COVID-19 really made it plain for many to see. And so I had the honor and privilege of serving on the steering committee for the recent Aacr Inaugural Cancer Disparities Progress Report. And it really attenuated to this sort of multifactorial model of health disparities, especially cancer health disparities, realizing that, when we see these health disparities, it's not just a single factor that's responsible for the adverse outcomes, but it also attenuates to the complexity and the interrelatedness of various factors that produce these adverse health outcomes, or these inequalities, as we call them. So it's not just biological or genetic factors that account for the differences we see, or cancer health disparities, but there's also psychological factors such as stress and mental health, or cultural factors such as one's cultural belief or cultural health beliefs, different social factors such as education, income, employment, health literacy, clinical factors that should be accounted for as relates to access to healthcare or quality of healthcare. And then environmental factors, again, attenuating to the built environment, and then behavioral factors, tobacco usage, diet, excessive body weight, physical inactivity, and then adherence to secondary prevention measures. So it's a multifactorial model where just not one factor is responsible for these adverse health outcomes, but you have to consider multiple factors that are involved in this process. And so I think going forward, we're going to have to better understand and better apply models that help us frame our intervention strategies to help overcome some of these challenges. I like the National Institute of Minority Health and Health Disparities Research Framework because it really attenuates to multiple levels of influence and multiple domains of influence, and how together synergistically health outcomes are seen. And so you read this model, I guess from right to left, realizing the societal impact, and these are some of the factors that could be addressed at the societal level under levels of influence, and these are some of the domains that could be addressed through this societal approach. But looking at the societal impact on the community and the community impact on interpersonal relationships, and also how those interpersonal relationships then inform individual levels of influence. And again, looking across a variety of domains, whether they're biological or behavioral or physical or built environment in scope, sociocultural, or health out, or the actual healthcare system, and then looking at it in the context of health outcomes. I think we're going to have to start looking at new models and new approaches as we better understand the role of social determinants and in the context of cancer health disparities, and as we begin to advance cancer health equity. We also must account for, different categorizations of social determinants of health. And why? Because it matters in terms of how you categorize a construct, but then most importantly, how you measure that construct consistently or in a standardized way across various populations, across different geographical settings, as well as across different populations. And so, like Healthy People 2030 categorization, these 5 unique categories, that really attenuates to some of the social determinants of health that we saw, adversely impact mostly African-American and Latinx populations, education and access and quality, economic stability, healthcare access and quality, neighborhood and built environment, as well as the social and the community context. And again, I think, having such strategies can help us really begin to change the picture of cancer in the state of Georgia. While cancer, again, just as a reminder, remains the second leading cause of death in the state of Georgia, the second leading cause of death. So, we know we've made tremendous progress in terms of better understanding cancer, preventing it, diagnosing it, treating it, even attenuating to the late and long-term effects of cancer treatment, but yet it still remains the second leading cause of death. So it shows us that we have work to do. And then again, the 4 types of cancer, we have to begin, to put forth real strategies that address, disparities in lung cancer, disparities in colorectal cancer, breast, as well as prostate, because we realize that these cancers account for more than half of all cancer related deaths. And then again, looking at different populations, in the context of place or the social determinants that they're more likely to encounter. And again, developing strategies and models that help address the multifactorial nature of cancer health disparities. These will all be important. And I think a good starting place for us, and again, this has been my experience through GC3, is a Georgia Cancer Plan. This cancer plan is published every 5 years, and it really serves as a guide or offers a strategic vision to really help assist us in reducing the cancer burden right here in the state of Georgia. And so, in the next couple of slides, I just want to highlight some key aspects of the cancer plan and how, strategies that we've put in the new cancer plan can really help guide us in the state of Georgia as we address cancer health disparities and also advance cancer health equity. So some of the approaches to addressing disparities in cancer control include representation. I think representation or raising the voice of those individuals or communities that are adversely impacted, really help create this shared model of governance, of power, as well as approach. And so having stakeholders and clinical providers involved in the process of improving knowledge and practices that really help us get those individuals in early, where they can benefit from early detection, especially for those, those non-screenable, cancers. Connecting and informing professionals and providers and patients, as well as organizations and institutions throughout the state of Georgia about best practices around palliative care, the strength of networking and offering educational opportunities to health systems and everyone within the health system, from the provider to the patients to just the organization itself, which is often comprised of a diverse cadre of health professionals. But presenting these educational opportunities to ensure that there's standards of quality that are attended to in the delivery of care, as well as in the prevention of cancer. And then also looking at survivorship, ensuring that it's inclusive and relevant. And National Academy of Medicine, formerly known as the Institute of Medicine, about 10, almost 15 years ago, released a report entitled Loss and Transition that really chronicled the fragmented healthcare system that most cancer survivors are left to encounter. And there were key strategies that were put forth, including patient navigation, as well as treatment summaries and survivorship care plans that every patient should receive prior to transitioning back to their primary care provider. And so, making sure that, the survivorship landscape is inclusive as well as relevant, whether one resides, in a geographically diverse setting or not. Making sure that language is attended to, the specificity of the cancer type and some of the late and long-term effects, germane to that particular cancer type. I think it will be extremely important going forward as we begin to, put forth intervention strategies in the cancer control space to really help address some of these issues that we're seeing among various populations. Then, of course, health literacy is extremely important, and then realizing again the context that poverty creates, or low income or low education areas create, and then helping overcome those barriers that oftentimes presented as a result of poverty. I'm using surveillance and assessments to monitor disparities, as it relates to early detection and screening. And this could be achieved or accomplished working directly with health systems, again, in metro as well as non-metro areas, as well as providers, to, really attenuate, how we're doing, sort of our measuring stick as it relates to those individuals taking the necessary actions to prevent cancer. But then in the event that one has an abnormal screening result, that they're getting in a sufficient amount of time and being, looked at or cared for. Another strategy is to seek Medicaid as well as state health benefit plan reimbursement for cancer control services. This is inclusive of prevention, diagnostics, treatment, palliation, as well as survivorship care. And then encourage Georgia-based epidemiological and disparity research on prostate cancer screening, which is still a conundrum, but realizing that it impacts still African-American men at such a disproportionate rate in terms of incidence as well as mortality. And so especially in our non-metro areas. And so there's more work to be done in terms of how we deliver informed decision-making, or that shared decision-making model that patients are expected to have or engage in with their healthcare provider. And then also looking at risk factor classification and effectiveness, again, as we work toward better understanding, why African-American men are disproportionately impacted by prostate cancer. Other approaches that this new Georgia Cancer Control Plan advocates for is to reduce disparities in screening rates among people, groups, as well as populations throughout the state of Georgia. And how is this, or how will this be accomplished? Well, first, by pursuing resources for screening, including genetic screening, especially among low income and uninsured populations, and going back to the distribution of poverty rates and where these individuals mostly reside. We know in the South, but we know that there's a large representation also in our non-metro areas. So, again, our strategies in terms of developing interventions to help overcome some of these adverse outcomes, could be pinpointed utilizing, that data. Also sustaining existing community-based screening programs that screen uninsured and underinsured groups, especially those that screen more than 60% of patients from racial and ethnic minority groups. So I think that's going to be extremely important going forward. And then facilitate access to high quality patient-centered cancer screening. And again, for those screenable cancers, lung, colorectal, cervical, and breast, for all Georgians, regardless of income, race, insurance, or employment status. And then, another aspect that we saw really amplified during the pandemic was this whole notion of acquisition of and trustworthiness of health information. And so we must begin to develop and test messaging among groups with historically low screening rates, and other high-risk populations. We must actively include them in the process from the beginning to the end as it relates to developing messaging that will increase individuals' awareness, their knowledge, and hopefully change their behavior as it relates to screening. We also want to increase provider education on best practices aimed at improving health outcomes, especially among those populations that have not enjoyed their a fair share of engagement with the healthcare system. So there may be some hesitancy, there may be some a lack of trust, there may be issues around safety, maybe issues around privacy that should be addressed. And so it's important for providers, to understand some of the best practices and engage in these communities that historically have been disproportionately impacted by cancer. And then lastly, we have to reduce diagnosis, staging, and treatment disparities. We still have many individuals that are being diagnosed at a late stage, especially for those cancers that are screenable. And so we have to do a better job at getting the information out, but then also ensuring once individuals encounter the healthcare system that they follow through based on provider recommendations. And we've seen that navigation is a key strategy to help eliminate any delay from diagnosis to the onset of their initial or first course of treatment. And so what role do you have in all of this? I'm glad that you're asked. You are extremely important toward addressing these issues. I like to call it a multi-sectorial approach is what we're after. I think that's the nexus, as you'll see, in coming years of individuals from various sectors of society coming together to address the complexities around a particular condition, and in this case, cancer. But a lot of the issues are cross-cutting for other chronic conditions as well. And so they could actually be addressed in tandem or parallel. And so some of the strategies that the cancer plan is calling for as it relates to multi-sectorial approaches includes a role for elected officials. There's more and more now a focus on, the political determinants of health, realizing that state and local state, as well as national policy, is a key factor, toward addressing and cancer health disparities, but then also advancing cancer health equity. And this could entail sponsoring legislation that promotes cancer prevention and control, appropriating funding for comprehensive cancer control in the state, realizing, especially here in the state of Georgia, that many individuals, almost forsake and the engagement of the healthcare system as it relates to cancer prevention and control efforts because of other competing priorities. And then advocate for a stronger statewide comprehensive smoke-free air bill. There's a role for local health departments, and local health departments are, sort of the connectors in the community, if you will, to the state Department of Health, as well as other agencies in various community settings, again, metro as well as non-metro areas. And some of the role or activities of the health departments could entail, and again, looking across sector in collaboration with different sectors to provide cancer awareness information to employees as well as their catchment area or the local community in which they serve. Facilitate healthy lifestyle campaigns. We know that obesity, some have projected obesity will become the primary risk factor for cancer, replacing tobacco usage. And so there's work to be done in that regard. Work with physicians to promote screening programs and case reporting. And oftentimes some of these activities may have to be decentralized out of the healthcare system and taken into areas where individuals may not live in close proximity to a healthcare system for such secondary prevention activities. And then provide space for survivor support groups, realizing that mental health and stress are extremely important factors in the context of survivorship. And then hospitals have a key role as well as professional organizations. I'm not going to go through every strategy or activity, but these are just a few that are listed within our state cancer plan. And so really convening and fostering groups around cancer awareness, knowledge transfer as well as making sure providers and healthcare professionals have the most recent practice strategies that are germane to meeting the needs of patients as well as their family members. And then community and faith-based organizations are extremely important, in this as well. I mean, I work with a lot of faith-based organizations and different community members toward, really helping get the word out about, cancer prevention and control strategies, participation in clinical trials, addressing some of the barriers and facilitators to clinical trial participation. And then what are some effective models for collaboration? Schools and universities, are extremely key for helping, secure robust funding to help fund some of these initiatives. And then employers have a role in maintaining a healthy workforce and promoting some strategies for such. And then, of course, the physicians, they're going to be extremely key going forward in terms of referring patients to the Georgia Tobacco Quit line, making sure patients are getting their appropriate screenings, reporting cancer cases in a timely manner, making early referrals for hospice or to hospice for end-of-life care, and then this model of coordination of specialists in primary care to really attend to the survivors' health needs, and ensuring that they're met, but then also for their caregivers, because we know that caregiver burden is emerging as a key topic in some of the different cancer types. And so, again, advocating for a multi-sectorial approach that really brings us all together and attenuating back to, what made the National Cancer Act possible, realizing that it was a diverse set of stakeholders who all came together to address this issue. Well, we're going to have to, ensue with a very similar approach as it relates to, addressing cancer health disparities, but even more importantly, advancing cancer health equity. And I think what will get us there are, looking at various sectors, inviting these various sectors to the table and coming up with a comprehensive statewide plan. And that is just what we did through GC3. We have such a dynamic group of individuals, over 80 organizations across the state of Georgia that have, taken up membership in GC3. Whether it's community and faith-based organizations, schools and universities, physicians, employers, or government officials, just to name a few, all have come together to bring their expertise, to bring their models and approaches together. So collaboratively, we can address some of the disparities that we see here in the state of Georgia and really advance cancer health equity. So with that, I will stop and take any questions.
Hello. Could you, this is a great presentation, Dr. Rivers. Can you expand upon the cultural factors you referred to in the health department?
On health disparities?
Oh, in the context of health disparities.
I'm sorry, health disparities, yes.
Sure. Thank you for that question, and thank you for tuning in. And we are extremely excited to see so many participants on this Friday morning. And so cultural factors related to health disparities and health equity that have been framed are often, of course, unique to different populations. So for African Americans, for example, some of the cultural factors that we see as it relates to healthcare seeking behavior, or participation in biomedical research, or even thinking about participating in cancer clinical trials, include their belief system, includes aspects of awareness and knowledge. More specifically, we know some factors such as privacy, and trust or mistrust related to researchers, related to healthcare providers, as well as healthcare systems are germane and more pronounced among certain populations in relationship to others. And for some, there's some validity. For example, with African Americans and thinking about the historicity of events that took place on the campus of Tuskegee University, the syphilis study, if you will. And we are stating a multi-generational effect of those events that took place, in that area. And oftentimes we, hypothesize that's why we see so many of the southern states, that lag behind the rest of the country, as it relates to making advances and having better health outcomes. And so those are just a few of the cultural factors that we have studied and researched and published data around, particularly as it relates to participation in biomedical research, because we know participation in research as well as clinical trials is extremely important, because without adequate representation, we know that we can advance disparities among some groups, and that's something that we don't want to do.
And we have another question. Thank you. Thanks, Brian. Could you expand on your vision for genetic screenings for risk and prognosis?
Sure. So, I think that question is in tandem with the cultural factors. So, we still have more work to do in terms of better understanding who genetic screening and genetic, counseling is most appropriate for, what cancer types, what stage, what grade of disease one may have. All are factors that really dictate, how one engages in terms of as it relates to genetic counseling and genetic testing. We're still developing the evidence. There's a lot of work being done across the country, hugely funded by the National Cancer Institute. We have the Cancer Genome Atlas, Aacr, the American Association for Cancer Research. They have a biorepository entitled Genie. We're doing some work in collaboration with many of the partners represented at this meeting at Morehouse School of Medicine, really trying to advance our understanding of these genetic mutations and if there's variance between groups or even within groups. So while the evidence space is still emerging, we have to be cautious in terms of how we apply it in clinical practice, because I don't think the evidence is, very well developed for most cancers. For some cancers, we're clear about different mutations, such as an individual with triple negative breast cancer, then they would be a good candidate. But then, with other indications, we're not as clear. The data is still emerging. And again, we want to make sure that the data is representative of all individuals to account, for their unique genome, as opposed to generalizing the data that, is a result of only a select type of population represented in research studies.
So thank you. And how can we really impact communication statewide with new models? And are there models that you are familiar with that you could?
Well, I'm a huge fan of multi-level communication models. I think, this is an extremely important question, and, especially, finding ourselves in the midst of this pandemic and realizing that health communication was a key factor that either eroded vaccine hesitancy, or enhanced vaccine hesitancy. So having mediums and channels that are trustworthy, especially in the rural sector, where the information is disseminated, it's received, it's trusted, but then it's actionable as well. We have to do a better job in that regard. And, I wish I had a generalizable model that we can just, apply to all. But I think one thing, if you didn't gather anything else from my presentation, is that it's a very unique process or implementation strategy that's needed based on where one resides, whether it's rural or urban areas, based on the affiliation of the racial and ethnic group, or based on affiliation of other demographic factors. It's a very unique approach. So while some may, gravitate toward utilizing social media, as a key communication tool, others may, be more inclined to respond to briefs. If you're interacting with, key state legislatures, they just want a one-pager or a policy brief. And so I think it's going to entail a multi-level communication strategy that really meets the needs of all individuals, as opposed to, looking at one particular strategy and say, I send this tweet out and everybody should respond, right? And again, we saw some of these hiccups during the pandemic when they were attempting to communicate information. information. And then there's some agencies found, the faith-based setting as a key communication site, especially in rural areas. And so really understanding, what works for who, when, how, where, and why is extremely important toward employing our approach.
There are multiple questions from some of the same people, so I'm just going to skip it down to another person, which is knowing that food insecurity impacts many Georgia residents. Do we know the impact of food issues on people with cancer?
And surprisingly, that was an emerging factor that was surprising to, I must admit, even to myself. And we see it here in Atlanta. When you hear about food insecurities or food deserts or areas or geographical settings that lack proper grocery stores or other entities where food is supplied, you always think, well, maybe that's in a rural area or a less developed area or a more fragmented community. But to our surprise, we saw many individuals and families, that encounter certain magnitudes of food insecurities. And so, going forward, I think we need to, again, ensue with a multi-sectorial approach where we're having the USDA represented in some of our advisory meetings or advisory boards to help inform us on strategies in terms of how we can best address these. As an example, I think Grady Hospital, we work very closely with, Pooja Misra. She's the executive director of the cancer service lines at the Cancer Center at Grady, and Dr. Roland Matthews and others. And what they put in place in terms of a food pharmacy. So individuals, patients who actually come in who have need, for food can actually get a prescription to go down to their food pharmacy, and it actually replaced where their McDonald's was. So how ironic is that? But how great is that at the same time? Because we know that, fast food is a driver of obesity, and we know obesity soon will probably overtake tobacco as a primary risk factor for cancer. And so, food matters. And having that food pharmacy, I think, is an example in terms of how we overcome. But then also during the pandemic, we saw key collaborations with our faith-based organizations. I think there's a church out in Decatur that Pastor Jamal Bryant pastors, and they have to date serviced nearly 1 million families. They have distributed free food to over 1 million families here in Atlanta, a robust metropolitan area. So just imagine some of the food insecurities around the state of Georgia where you don't have such access to a Kroger or a Publix or a Whole Foods. And so this is something that I think we need to incorporate in our multifactorial model as we begin to better understand the context for cancer prevention and control.
I would just add to that. I just left the U.S. Conference of Mayors, and one of the mayors, the mayor of Denver, Michael Hancock, said that their assessment of food insecurity during this COVID period actually moved from 1 in 10 residents of Denver to 1 in 4. In other words, the circumstance got much, much worse.
Wow.
And that's across just the general population. So, it is something that we need to pay attention. So there's a administrative question here for you, Denise. Would the slides be made available?
Yes, Dr. Rivers is okay with that. We'd be happy to make the slides available. Sure.
Yeah.
And we have about another minute or two,
Okay.
so maybe we'll take a couple more questions.
What is your vision for Georgia-Alabama partnership, and how can future researchers support this work?
So, thanks for that question. And so what that question may be referring to is that Morehouse School of Medicine has a partnership with UAB as well as Tuskegee, funded through the National Cancer Institute, Partnerships to Advance Cancer Health Equity consortium. So we're in a triad. And this partnership existed prior to Georgia actually having an NCI designated cancer center. And that's one of the requirements of this triad. But, similar to Alabama, I think the vision for the state of Georgia is that, our Georgia State Cancer Plan will help drive a lot of the implementation strategies that we've used with our state epidemiologists and working with DPH and Georgia Core and other agencies around the state, PB Health System, Daryl Sabbs and his team, and just better understanding the context of, what needs to happen in the state of Georgia. Like I always say, what's good for Alabama may not necessarily be good for Georgia. What's good for Georgia may not necessarily be good for California. So we have to uniquely administer our approach. And I think we have an excellent strategy in place with the Winship Cancer Institute, and we have other agencies, Morehouse School of Medicine, Cancer Health Equity Institute, Georgia Core, Grady, a key partner. We have this outstanding Georgia Cancer Plan that took a lot of work to draft, but it's representative of over 32 agencies and organizations' input. And taking those strategies and employing them systematically, collaboratively, though. I mean, again, this needs to be a multi-sectorial approach. And you're going to hear throughout the day about our roundtables. You're going to hear about, our work groups, our regional cancer coalitions, all strategies to help implement what we think are evidence-based approaches to overcome these dire statistics related to cancer and its impact on the residents in the state of Georgia. A key strategy I think you're going to see more and more of is the application. I think Dr. Hotz mentioned in his presentation of the community health worker model and the patient navigation model. It really provides a great nexus. For those unfamiliar with the model, Harold Freeman developed the patient navigation model in Harlem, New York, when African-American women were coming in, getting the diagnosis of breast cancer, but then delaying their initiation for the first course of treatment. And he came up with this model where you call individuals out from impacted communities because they have the cultural capital to interface and they're trusted as well. And you retool them, you retrain them, and then you put them back in the impacted communities and you allow them to help, navigate individuals to the health system. You're going to see more and more of that, different iterations. So you may see some that are clinic-based, you may see some that are community-based, you may see clinical trial navigators, you may see nurse navigators. So many different iterations of that model. I think you're going to see more and more of as a key strategy to really help us implement some of the key recommendations from the cancer plan.
So Dr. Rivers, this has been wonderful. Can you tell our audience, or perhaps it'll be on the slides, how they can follow the work that you're doing through these various partnerships? Is
Sure.
there a website or something that
There is. So, of course, I can be reached at B as in boy, Rivers at msm.edu. brivers@msm.edu. You can always follow us at msm.edu. You can also follow the work that we're doing at the state level through Georgia Core or GC3, our Cancer Control Consortium. And then just almost everybody on this meeting register, our collaborative framework, because that's one thing I want everyone to take. It's going to take away from the presentation. It's going to take all of us together collaboratively in the state of Georgia and really advancing some of our cancer prevention and control initiatives. So we're extremely excited about the opportunity.
Thank you so much.
Thank you.
Thank you so much. Denise, am I turning it over to you?
I'm sorry that we'll have to cut our questions a little bit short. This has been a wonderful discussion, but we do want to take a short bio break before our next session, which will start promptly at 10 o'clock. You'll go to the breakout rooms, and the sessions, there are 3 sessions: cancer screening and early detection. The second is innovation in genetic screening for pancreatic cancer, and HPV vaccination is the third option. So you'll select one of those in the breakout room at 10 o'clock. Please also remember to click on the evaluation form on the lobby screen and start filling out your evaluation if you haven't done so far. So thank you very much, Mayor Franklin, and thank you, Dr. Rivers, for such a fine presentation.
Thank you, Denise.
Thank you. Have a wonderful day.
You too. Thank you.